Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Valneva.
This program is presented by Medscape Education Global.
Hello, I'm Francesca Norman. I'm a consultant at the Topical Medicine Referral Unit of the Ramon y Cajal Hospital in Madrid, Spain, and I would like to welcome you to this program titled Chikungunya Virus Vaccine, a new addition to the travel vaccine Armamentarium. Just briefly, if we look at the program overview, this program will consist of 3 chapters, and they will cover, firstly, an update on chikungunya burden, followed by our second chapter on the latest clinical data on chikungunya virus vaccines, and finally, chapter 3 on how to identify who can benefit from chikungunya virus vaccine. So let's get started. This first chapter will focus on updated data on chikungunya. So chikungunya virus is an alpha virus. It is an arbovirus as well, which means it is transmitted by the arthropod bites, in this case mainly mosquitoes, Aedes aegypti and Aedes albopictus, as shown in the figure. And interestingly, before 2014, this virus had a fairly limited geographic distribution, mainly countries in Africa and Asia. And after 2014, with introduction of the virus into the Caribbean and spread to the American continent, we can see on the map that there was much more wide distribution of this virus. This is an excellent review which I can recommend, published last year, Nature Review Disease Primers, which illustrates well the current distribution of the vectors for chikungunya and the predicted spread due to climate change and other factors. We can also see distribution of the various lineages of the virus. So if we look at recent epidemiological data on the burden of disease worldwide, well, chikungunya cases from May of 2023 to April 2024 have mainly been distributed in areas of Latin America, some cases in Africa, and also some cases in Asia. But really, countries which have been most affected by outbreaks recently have been countries in South America. This ECDC data, updated May 2024, reflects this. From the beginning of the year to 30th of April, there have been approximately 240,000 chikungunya cases and over 90 deaths reported worldwide. As mentioned, countries with most cases have been Brazil, Paraguay, Argentina, and Bolivia. So far, there have been no locally acquired cases in continental Europe. So what about the clinical manifestations of chikungunya infection? Usually, after a short incubation period of maybe 3 to 7 days approximately, there is an acute phase. Most chikungunya infections are in fact symptomatic, and patients will experience fever, a rash possibly, and particularly for this infection, a lot of manifestations involving the joints. The acute stage usually lasts less than 3 weeks, and some patients may have additional complications, for example, neurological involvement, cardiac involvement, and even ocular involvement. And risk factors which have been identified for these complications are advanced age, the presence of comorbidities, and also pregnancy. After this, some patients will experience post-acute stage, which may last from 3 weeks to 3 months, and there is persistence of symptoms. And approximately 50% of patients, from 25 to 50% of patients, may go into a chronic stage, lasting more than 3 months. If we review chronic disease, as mentioned, this does not occur in the majority of patients, but there is a substantial morbidity associated with this infection. Regarding chikungunya mortality, overall, this has been reported to be fairly low, less than 1%. However, recent data have shown that chikungunya-associated mortality may be higher in specific risk groups, around 10%, mainly in patients with comorbidities such as diabetes or patients who manifest and have cardiac and neurological involvement. In fact, there is a very recent study which was published this year a Brazilian cohort examining patients with chikungunya disease, which has shown that there may be an increased risk of death even up to 84 days after onset of chikungunya infection, not always due to the infection per se, but other associated causes of death such as cerebrovascular diseases, ischemic heart disease, and even decompensation of diabetes. So what are some of the challenges in diagnosing chikungunya infection? Well, usually it is very important to know the geographical distribution for the infection. However, the endemic area is expanding, vector competence might be increasing, and also we need to identify the incubation period. And this may be hard for patients presenting in later stages, in the post-acute stages and in the chronic stages. Also, I would like to highlight sometimes it is difficult to identify the clinical picture. Symptoms may be non-specific, there may be overlap with other arboviral diseases, and in the chronic stage, it may be difficult to make an adequate differential diagnosis with other causes of arthritis. Also, even if we suspect the disease, there may be difficulty accessing specific diagnostic testing for confirmation of the infection. If we look at some of the non-specific clinical manifestations of the infection, I would like to illustrate with some images from patients. We can see we may have a patient with a non-specific rash. We may think this is an arboviral disease such as dengue, chikungunya, etc., where in actual fact it may be due to another infection such as rickettsial infection. Joint involvement, which is fairly typical of chikungunya, may also present in other infections such as Zika virus infection. And also rashes may be difficult to interpret. We usually associate petechial rashes with dengue virus or even with other serious infections. And in actual fact, chikungunya may also sometimes present with lower platelets and a petechial rash. So how do we diagnose chikungunya infection? Well, first we need to know it exists. So we are able to include it in the differential diagnosis. We need to identify the risk factors in the clinical picture. Is this a patient who may have been exposed in an endemic area to the virus and to the vector? And then we need to order the correct tests. Now, the tests that we may order may depend on the phase of the disease. So in the acute phase, there will be viremia, so virus will be present in blood, and we can diagnose the infection using PCR techniques. Serology may become positive after a few days of symptom onset, and in the chronic phase, usually we will only be able to diagnose past chikungunya infection with chikungunya IgG and excluding other causes of arthritis. For all this, we need the support of a specialized lab. Not all these tests specific for chikungunya will be available at all laboratories in all areas. So how do we raise awareness about the infection? Well, there's several data which illustrate the fact that even during epidemics of arboviral disease, patients may not undergo confirmatory testing. For example, when there are outbreaks of these diseases with such non-specific clinical pictures, some of the infections may be diagnosed as dengue infection, which is actually more frequent. However, chikungunya may present in with various clinical manifestations and has been shown to be a significant cause of viral encephalitis during outbreaks and epidemics. If we look at this recent paper on reflecting on the current outbreak for Brazil with dengue infection, official data from one of the states, Minas Gerais, has shown that if the absolute number of positive tests for chikungunya are analyzed, we can see that in certain areas, the diagnosis of chikungunya is actually higher than for dengue. So we need to be aware that this infection may also be circulating. If we look at data for travelers, this is a very nice paper which has been recently published and reflects on data from the GeoSentinel network and analyzes chikungunya acquired by international travelers, which has data from 100 destinations globally. In total, the analysis for 15 years, they analyzed data on over 1,200 travelers. And one of the key messages are that vector precautions and vaccination advice should be integrated into the pre-travel visit. They also highlight the importance of continued surveillance of travel-related chikungunya, as this may help public health officials and clinicians limit transmission by defining regions where protective measures should be considered. So in summary, to highlight, I think it is important to raise awareness of the disease, not only for health professionals, but also for patients and travelers who may be traveling to endemic areas. And also, we need to invest in multidisciplinary preparedness, such as initiatives led by the WHO on arboviral diseases. I would like to thank you very much for your attention, and please move on to the next chapter, which will cover the clinical trial data on chikungunya vaccines.
Hello, I'm Christopher Morris, Professor of Global Health at the Milken Institute School of Public Health at the George Washington University in Washington, D.C. Welcome to this chapter entitled Latest Clinical Data on Chikungunya Virus Vaccines. So Francesca updated us on the burden of chikungunya virus-related disease and its symptoms, and given the increasing global impact she described, there's been a significant effort to develop vaccines against chikungunya virus, and today I will share with you the latest available data on these vaccine candidates. Here we can see the depth of potential vaccines against chikungunya under development that have reached the clinical trials phase. A variety of constructs are evident here, from whole virus to subunit, mRNA, and viral vector. Importantly, the approach is shared among these to present the highly immunogenic envelope glycoproteins and structural capsid protein, often in combination with other chikungunya viral elements. The following will focus on the most advanced candidates that have reached or finished phase 3 trials. VLA1553 is a live attenuated chikungunya virus vaccine. The attenuation comes from a deletion in the non-structural protein NSP3, but that is otherwise replication competent and presents all viral structural proteins to the vaccinee. VLA1553 received FDA approval in November 2023 and an EMA CHMP positive opinion in May 2024 on the basis of its performance in phase 3 trials. The VLA1553 critical phase 3 trial was a US-based, multi-center, randomized, placebo-controlled, double-blind protocol that enrolled 4,128 healthy adults greater than 18 years of age to receive a single dose of vaccine or placebo in a 3-to-1 ratio. The final endpoint for the trial was a seroresponse of chikungunya-specific neutralizing antibody titers exceeding a dilution of 1 to 150. This use of an immune correlative protection was agreed upon with regulators in advance of the trial and is based on the improbability of observing sufficient number of chikungunya cases during the trial period to allow evaluation of clinical outcomes efficacy. VLA1553 followed a per-protocol analysis of a subset of vaccinees whose sera were tested for neutralizing antibodies against chikungunya. By day 29, the seroresponse rate was 98.9% among those who received VLA1553 versus 0% in the placebo control arm. This seroresponse rate was maintained for over 6 months of follow-up. Safety profile for VLA1553 during this phase 3 trial was promising. The vaccine was well tolerated, with localized injection site adverse events being similar to controls and systemic reactions being generally mild. These were typically fatigue, headache, myalgia, nausea, and fever. A long-term immune durability study was done on VLA1553, where 363 participants were enrolled from the pivotal phase 3 trial for annual antibody titer checks up to 5 years post-vaccination. Additionally, safety data would be collected during the first 2 years of this study. An interim readout of this study showed the seroresponse rate among participants remained robust at 97% for the first 24 months post-vaccination. The safety data from this 24-month readout was similarly positive, with no severe adverse events being associated with VLA1553 vaccination. A sub-analysis of this trial looked at the seroresponse rate among vaccinees greater than 65 years old as compared to 18 to 64-year-olds. No differences were found between these age groups with regards to their antibody titer levels, and all maintained high levels of neutralizing antibodies chikungunya for the first 24 months of follow-up. This study is still collecting data on immune durability. A separate phase 3 pivotal trial of VLA1553 was performed in healthy 12 to 18-year-olds who lived in an endemic country for chikungunya. Results were robust, with 99% of baseline seronegative participants meeting neutralizing antibody titers correlated with protection by day 28. The safety profile remained promising, with 1 SAE of grade 4 fever reported among VLA1553 recipients. Of interest in this study was the finding that VLA1553 vaccinees had neutralizing antibody titers similar to those participants who were baseline seropositive for chikungunya due to natural exposure. Another advanced candidate is PXVX0317 CHIK. This vaccine uses a virus-like particle design where the structural proteins of chikungunya virus are assembled into their natural conformation, but the particles do not contain nucleic acids required for viral replication. In some cases, this approach can yield enhances in cold chain durability and safety profiles over attenuation of replicating viral vaccines, but often these require the addition of adjuvants or additional boosters. PXVX0317 CHIK is adjuvanted with aluminum hydroxide and used a 2-shot sequence during phase 2 trials. However, During phase 3, the vaccine schedule was reduced to a single injection. PXVX0317 CHIK was submitted as a marketing authorization application to the EMA in June of 2024 based on phase 3 trial data. The PXVX0317 CHIK pivotal phase 3 trial was a multi-center randomized placebo-controlled double-blind protocol that enrolled 3,254 healthy adults and adolescents to receive a single dose of vaccine or placebo. By day 22, PXVX0317 CHIK vaccinees showed a seroresponse rate of 98%. This decayed slightly to 86% by 6 months post-vaccination, with long-term follow-up studies underway. The safety profile of PXVX0317 CHIK was promising, with the vaccine being well tolerated, and the most common AEs being myalgia, fatigue, and headache. Another chikungunya vaccine candidate undergoing clinical trials is BBV87. BBV87 is an inactivated whole virus chikungunya vaccine. It's delivered with aluminum hydroxide as an adjuvant. It requires 2 doses and is currently undergoing phase 2-3 trials in sites in Southeast Asia and Latin America. Another chikungunya vaccine candidate is MV-CHIK. MV-CHIK is a live attenuated measles vectored vaccine that contains the structural proteins of chikungunya virus. Phase 2 data was promising with a 96% seroresponse rate and no interference from prior measles immunity. It was safe and well tolerated and was awarded an FDA Fast Track and EMA Prime designation. MV-CHIK has not as yet moved into phase 3 trials. mRNA-1388 is a single-stranded RNA molecule encoding the structural proteins of chikungunya. This vaccine has undergone phase 1 trials. ChAdOx1 is a replication-deficient simian adenovirus vectored vaccine that encodes the chikungunya structural proteins as well. This vaccine has also undergone some phase 1 trials, but is yet to progress to phase 2. In conclusion, our scientific understanding of how to elicit strong, likely protective immune responses to alpha viral proteins like chikungunyas through vaccination is robust. Phase 3 studies were an impediment to potential candidates due to the unpredictable nature of outbreaks. However, FDA and EMA acceptance of immune surrogates of protection has allowed multiple products to advance. Clinicians should take note of these prophylactic products as they come to market in order to better serve at-risk persons for chikungunya exposure. Thank you for watching this chapter. Please move on to the next chapter with Inés Escuelan Rivera, where she will cover how to identify those who can benefit best from chikungunya virus vaccines.
Hello, I'm Inés Escuelan Rivera, professor in the Department of Pediatrics at the University of Puerto Rico School of Medicine in San Juan, Puerto Rico. Welcome to this last chapter titled How to Identify Who Can Benefit from Chikungunya Virus Vaccine. So, Christopher updated us on the latest clinical data on chikungunya virus vaccine and described some promising results from those in late-stage development. Now that one of these vaccines, the BLA1553, is available in the US and has also recently been granted marketing authorization in the European Union, it is important for us to consider how we can determine which patients will benefit from receiving the chikungunya vaccine. Since its description in 1952, chikungunya virus has caused 10 million of human infections. It is estimated that 1.3 billion people live in areas at risk for chikungunya virus infection, including Europe. Chikungunya virus disease cases and outbreaks have been identified in more than 100 countries in the Americas, Africa, Asia, Europe, and the Indian and Pacific Oceans. Notably affected countries right now are Brazil, Paraguay, Argentina, and Bolivia. Since 2013, when the first locally acquired cases of chikungunya were reported in Americas on the islands of the Caribbean, the virus has continued to circulate and cause sporadic cases and periodic outbreaks in many areas of the world. Infection is most commonly acquired in locations of Asia and the Americas. The greatest risk factor for travelers is traveling to an area where there is an outbreak. Paraguay is a country with a population of 6.7 million people and reported more than 85,000 chikungunya cases last year. The annual cumulative incidence in Paraguay last year was 1,154 cases per 100,000 inhabitants. Paraguay reported 23 deaths and more than 8,000 hospitalizations last year. This graph comes from the CDC ARPANET, and the first one represents the percentage of all U.S. persons traveling to areas with chikungunya risk visiting Paraguay, and it was less than 1%. The second one represents the percentage of all reported U.S. traveler chikungunya cases who indicated that they had traveled to Paraguay. This is a clear example of a higher risk during an outbreak. We experienced chikungunya in Puerto Rico 10 years ago, and we found that the attack rate for this disease is very high. Most people that got infected got sick, and there was marked limitation for patients that were infected in terms of joint pain, fatigue, fever. Most people miss work for more than 2 weeks because of the disease. Children were not able to go to school. They were not able to play sports. There was a lot of long-term side effects of the disease like fatigue, joint problems. There are still susceptible persons in the island, and people remember well what was the disease, and they want to protect their loved ones from getting infected. So the key risk factors for chikungunya infection, besides traveling to an area with an outbreak, is the intensity of transmission. That is demonstrated by the seasonal variation in the mosquito activity, in the increased mosquito breeding sites, the cumulative duration of exposure, and the type of exposure. For example, moderate exposure represents travelers who might have at least 2 weeks of exposure to mosquitoes in outdoor or indoor settings. But limited exposure refers to, for example, business travelers likely to be mainly in mosquito-protected indoor settings. So the chikungunya vaccine recommendations are the following. The chikungunya vaccine is recommended for persons 18 years of age or older, traveling to a country or a territory where there is a chikungunya outbreak. The chikungunya vaccine may be considered for persons traveling to a country or territory without an outbreak but with evidence of chikungunya virus transmission among humans within the last 5 years. And these persons include those aged more than 65, especially those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, or persons staying for a cumulative period of 6 months or more. This is the chikungunya vaccination for U.S. travelers decision tree, and it was published by the CDC, and it provides important information for the healthcare providers. We should assess the risk of every person that will travel to an area where there has been chikungunya. It's very important for all the travelers to know that they should be applying protective measures for exposure to the mosquitoes in the areas that they will be visiting. And also, it is important for them to know if there is an ongoing outbreak, because for those older than 18 or older, the chikungunya vaccine is recommended. If there is chikungunya or has been chikungunya activity or transmission in the area within the last 5 years, then the vaccine may be considered, especially for those older than 65. And very important to remember that the risk is higher if they have underlying medical conditions, and for those that will be staying for 6 months cumulative or more. In those cases, the vaccine should be considered and administered. The key risk factors for severe disease include older age, underlying medical conditions, and those include diabetes, cardiac disease, renal disease, hypertension, but also obesity. Key risk factors for chronic arthralgia, which is very important with chikungunya, and older age and pre-existing joint problems that will be rheumatoid arthritis. The risk for higher morbidity and mortality in older persons was supported by the data from the recent outbreak in Paraguay, where there is clear evidence that the case fatality and the hospitalizations increase in the older age group. Then, what is the role of the physicians and the healthcare providers in advising patients who can benefit from the chikungunya vaccine? We need to ask questions about the type and the duration of exposure. It is important to know if this traveler is going to be mostly outdoors, on camping grounds, or mostly in a closed setting, let's say working or not doing outdoor activities. It is important to identify the risk factors for severe disease, as were those that I just mentioned, because there are certain patients that will have or are at risk of developing complications if they get the natural disease. We need to orient our patients about the chronic manifestations of chikungunya infection. There are patients that will develop chronic arthralgia, fatigue, and other symptoms associated with the disease, and that can last up to months or even years. They need to have that information. We need to provide evidence about the chikungunya virus transmission in the destination, not necessarily just only about an outbreak, but also about transmission within the last 5 years. We need to explore their knowledge of adverse events associated with the vaccine and discuss the probable risks versus the benefits of getting the vaccine. We need to assess contraindications for the chikungunya vaccine, which are mostly individuals who are immune deficient because of disease or medications that they require for treatment of chronic conditions, and that the vaccine is not recommended for pregnant women because there is no data on the safety of the vaccine in pregnant women. And also, there is information available through the Chikungunya CDC or ECDC that we can share with our patients. This is the CDC Chikungunya vaccine information for healthcare providers, and is very good information valuable to assess the likelihood of exposure to the chikungunya virus, to assess the risk for severe disease outcomes in our patients, and to also to assess the traveler preferences. There are factors that may influence the patient's decision on vaccination. There are personal perceptions and tolerance of risk, so we need to have an open discussion with our patients about what they consider will be the risk. We need to explore their knowledge about symptoms of chikungunya and possible long-term joint problems after infection, because for most people, this information is not readily available, so we need to have this discussion with them because that will affect their decision. The benefits and possible side effects of the vaccination will need to be discussed. We need to talk about outbreaks or ongoing disease activity at the destination, because if they have that information, they can make a more informed decision. The duration of travel or residence, including likelihood of future travel to an area with chikungunya, is important too. The likelihood of exposure to mosquitoes, depending on the setting that they will visit or they will be during the visit to the territory or the country. Their age, we have to emphasize that those older than 65 are an increased risk, especially if they have any risk factors, any medical conditions, as the one that I mentioned, for severe disease, diabetes, heart disease, renal disease, high blood pressure, obesity. All those are risk factors for severe disease. And also, we need to talk about conditions that may increase the risk of long-term joint pain after infection, because we know that patients with chronic arthritis, rheumatoid arthritis, are at high risk of developing chronic joint pain or exacerbation of their existing joint problems. So, to conclude this program, as Francesca described in the first chapter, various factors are increasing the global spread and the risk for chikungunya virus, with its clinical manifestations ranging from milder symptoms of fever, headache, joint pain, myalgia, and skin rash, to severe illness and mortality in more vulnerable populations like older adults and people with comorbidities. This increasing spread and risk has led to development of several vaccine candidates, with those in late-stage clinical development showing rapid and durable immune responses and favorable safety profiles, one of which is the live attenuated single-dose BLA 1553 vaccine that is now approved for use in the United States and European Union. Identifying persons who can benefit from vaccination should be based on the careful assessment of the risk for chikungunya virus infection. Having this new addition to the travel vaccine armamentarium will hopefully decrease the potentially serious outcomes and burden of chikungunya virus-related illness in an increasingly susceptible global population. So thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.